Welcome to today's Grand Rounds special presentation. This is a panel presentation. I am both presenter and host, along with Carrie McClain and Josh Jorgensen from the National Rural Health Association. They will each introduce themselves as each of us first tells our story of how it is that we became involved in advocacy and what it is about advocating for rural health that may be a bit different than advocating for other issues. And so I'm going to start with my story, and then Carrie and Josh will get a chance to tell theirs, and then we will take the time after that for back and forth and interaction. So we want you to be coming up with questions so that we can really make that an important and engaging time. So my story, I wrote an essay one time, which I entitled "To the Hill and Back." And it was written after a particularly exhilarating experience up on the Hill during the Policy Institute, the National Health Association Policy Institute, followed by some very disappointing news that I received in the airport on my way back home. But it illustrates a little bit my journey as an advocate for rural health. My experience in advocating for rural health really started growing up, but even more so in early practice as a rural physician in West Central Ohio. And a lot of my advocacy efforts in the beginning were directed toward concerns at the patient and community level. I was very much a local advocate. I would advocate for an individual patient before a specialist, or I would advocate for a group within our community to get some kind of accommodation by our local hospital. For example, the Amish had difficulty accessing our hospital because of the expense and because of a generally unwelcoming atmosphere among the staff, and worked over the years to help change that. I wasn't really engaged with on the national scene, nor did I understand how important my engagement was until 2003, when I started a program for medical students from Ohio State University to come to a cabin in the woods and spend some time focused on some topic in rural health. And the first Rural Health Scholars Retreat, we invited Steve Wilhide, who at that time was the president of the National Rural Health Association. As part of the program that I had designed, we chose two of the scholars to go with me to the Policy Institute and make a trip to the Hill. And that fellow sitting in front of the fireplace there in the green was one of our first two rural scholars. Since that time, I have gone to Washington every year, and here's the picture from 2019. 2019 was an important year for me because there were some things starting to move in rural medical education, and having a student interested in general surgery and another student interested in rural family medicine practice, and one of our faculty who one of these days I'm sure is going to run for Congress. It was a really interesting experience. Dawn Malika is the administrative director of our office, and she and I every year take several students. The students we took in 2003 formed the nucleus of a group that eventually resulted in the student constituency group at the National Rural Health Association. And now every year we have students attending our rural medical educators meeting in the day before the annual conference for the National Rural Health Association. I've been a part of the Ohio contingent every year when we go to the Policy Institute. And Mr. Wilhide was really my mentor and coach in the early going because he went with us the first 2 years. And then as time went on, I became the most senior member of the group generally. And the students and a few of us were the only people from the whole state of Ohio who would attend this institute. And so it was very much, our efforts were very much focused toward rural medical education. Every year, we made contact with our members of Congress, and over time have developed some relationships, which is really important. Last year, my congressman's aide connected me with Casey Quinn and Brad Wenstrup's office. He's from Cincinnati, Ohio, and although we had no students with us that year, Casey was very interested in the work that he was doing as co-chair of the House Ways and Means Task Force on Rural and Underserved Health. We met with them again this year, and it was amazing. I had given her information last year about some of our concerns around rural medical education, and in December suddenly got an email from a staffer for the House Ways and Means Committee who asked me to provide some really detailed information about rural medical education, rural residencies in particular. And I wasn't sure what they were going to do with that information. But imagine my surprise when the Consolidated Appropriations Act of 2021 was signed by President Trump just a few days before Christmas. And I came to find out it had 3 GME provisions in it that I've been advocating for 20 years. And finally was seeing some movement. It was a really gratifying experience, and getting the backstory from Casey as to how that all came down was really, really interesting to me. So persistence pays off. And I would just say that I discovered that sustained relationships with your members of Congress as a credible source of information is really important. And even more important, relationships with the staff. Although some staff turnover, there are others who have persisted over the years. Keep your message simple, keep it the same, and be ready when the time comes to provide the information they need, and expect things to maybe move more quickly. There were so many others involved in that story I just told that were working behind the scenes on the same issues I was concerned about. And it was really a matter of everything coming together and lining up. It really does take a team. And I learned that advocacy is less about persuading minds and more about establishing trust as a credible and responsive source of information. So I grew up, my family didn't participate in politics. My parents didn't vote. I don't think my parents ever voted. Grew up in a Mennonite home that believed in separation of church and state. And here I am now, strongly advocating in Washington, D.C. and in Columbus, Ohio, for the things that are important to me and to my community. With that, I'll turn it over to Carrie and Josh.
Well, thanks, Randy. I mean, I can't echo that story enough. I think that's really important, you know, creating those relationships with your members of Congress and with the staff to be a resource is really what Carrie and I try to stress in these conversations. So really appreciate it. And I guess I'll kind of start with my story, and then I'll let Carrie take hers. So if you want to go to the next slide quickly. Yeah. And again, just thank you to you and Audra for setting this up and inviting Carrie and I today. It's a lot of fun to be here. You know, just my name is Josh Jorgensen. I serve as the Government Affairs and Policy Manager here at the National Rural Health Association. As you can guess, given the advocacy angle that Randy talked about, we're based out of Washington, D.C., but I'm actually located right now in my hometown of Sioux Falls, South Dakota for this presentation today. So kind of have that rural flair going on right now. So just for a little background for me, like I said, I was raised here in Sioux Falls before going on to attend the University of South Dakota. And throughout my college career, I focused on political science and journalism. So I kind of come to rural health advocacy from more of the political side of things. And when it was in college, I was really interested in in politics at first, and then that kind of devolved and changed over to policy rather than politics. And I think there's a big difference. Both are very important, but policy, in my opinion, is really what can make a difference in people's lives in rural communities and urban communities and throughout different issue areas. And so right as I was about to graduate, my focus kind of shifted more towards policy rather than politics. And with a journalism and political science degree at the time, in kind of a simplistic view, I thought I'd either go to Washington, D.C. or Pierce, South Dakota. And I ended up picking Washington. I don't know if you've ever been to Pierce, South Dakota in the winter, but it's not the most fun. So I went to Washington. I got an internship with Senator Mike Rounds from South Dakota, and ended up working there for a little bit. And then I went to the American Enterprise Institute, where I worked with their external affairs team. AEI is a think tank in Washington, and essentially it was a great gig for somebody right outside of college. I went around the country and presented at different conferences and got to see places that I'd never been to coming from South Dakota. But I didn't really feel fulfilled in the sense that I was simply regurgitating other people's work, but not working on policy issues and trying to impact folks hands-on. So of 2016, I had the opportunity to go back to Senator Rounds' office and work on policy. And I spent nearly 4 years in that office working on healthcare, education, Native American issues, and then tech and telecom. And just given the nature of South Dakota being the rural state that it is, almost every one of those issues had a rural flair to it. But in particular, I was really excited to have the opportunity to work on rural healthcare and healthcare more broadly. I think like a lot of people with ties to rural America on this call, I've had a lot of friends growing up, and I saw it in the chat before here, who've dealt with substance abuse, mental health issues. And in my opinion, oftentimes that comes from one, a lack of resources in these communities, and at times, two, a lack of awareness about these issues in rural communities or with different members of our community. So when I was in Senator Rounds' office personally, one of my goals was trying to increase access to some of these important services in rural communities in my home state and obviously around the country if things got signed into law. So having the opportunity to work on these issues and focus more intimately into rural, mental health and substance abuse and things like that. I also learned about more of the issues that face rural communities. And I think Carrie and I will talk more about those later on in the presentation. But, even growing up in South Dakota and living in a rural community for the majority of my life, sometimes you never see what's right in front of your face until you dig a little deeper. And so having those 4 years on Capitol Hill were a fantastic learning experience for me. And about midway through last year of 2020, I began seeing if there were other avenues where I could share my experiences and, my quote unquote expertise, if that's what you call it. And I saw a job opening with the National Rural Health Association. And, I thought it would be a good fit for me. And I was hoping it would be a good fit for NRHA. And apparently they thought it was because they ended up offering me a job here. And then in October, Carrie McClain, my boss, joined, and we now have a great team that I think is kind of firing on all cylinders a little bit here and in advocating for rural health. So it's an issue I take great pride in. I'm really proud to come from a really rural part of the country and getting the opportunity to advocate on behalf of people I grew up with or part of my home state from this side of things rather than on Capitol Hill has been a really great pleasure. So I look forward to chatting with you all today about tips on how to advocate, some of the issues that face rural America and what Carrie and I kind of do on the day-to-day basis to advocate for rural America. So I'll go ahead and pass it over to Carrie and we'll talk more in a little bit.
All right. Well, hi, everybody. I'm Carrie McClain. I'm the Vice President of Government Affairs and Policy here at NRHA. And like Josh, we were neighbors separated by probably 14 hours of driving. But I am from the Midwest, depending on how you count it. I am a fifth generation Montanan. I have to say it kills me that my children were born in Washington, D.C., but we're going to get them out there to become Montanans at some point. I think my path, it's just funny to think about kind of, I know everyone says this, but you never really know where you're going to end up in your career and being open to opportunities and really kind of following the things that are interesting to you and sound fun and kind of drive your passion, I think has been a big way that my career has kind of evolved. So grew up in Montana. I did my undergrad at a small liberal arts school in Oregon, Willamette University. Went back to Montana for several years, I was an AmeriCorps member and then ran a statewide AmeriCorps program for several years working with university students. And then went to Syracuse University, the Maxwell School there, and got my master's in public administration. And my plan then was to just go to DC for a year or two and get some experience and then head back home. And 18 years, 19 years later, I'm still here, which means that I'm not any older than 25 for anybody who's asking. You know, I came to DC and my goal really was, I knew I wanted to do public service in some way. And so I wanted to get a flavor of what that looked like in the healthcare arena. And I looked at a lot of different places within HHS, and I found this agency that someone once described to me as the redheaded stepchild of the Department of Health and Human Services. And yet when you start to look at its mission, the mission of HRSA, for those of you who don't know it, the Health Resources and Services Administration, is essentially providing access to care for underserved populations. And that kind of spoke to me immediately. And I applied through a kind of a professional development program, career ladder kind of program there. And my first placement in that program was with the Federal Office of Rural Health Policy. And I stayed there for 7 years, working primarily in the policy arena. Like Josh, while I love some of the grant work and the program work, the policy piece just really speaks to me. It's the not fixing the issue after it's occurred, but how do we get further ahead of it and really prevent and make sure that we're creating programs and guidelines and everything else that work for people and mean that people can get access to care as needed. So I was in that federal office for, like I said, 7 years, worked my way through the policy chain, ultimately was deputy in that office, and was happily plugging along when the Affordable Care Act passed. And the HRSA administrator at the time asked me to come up to her office and help to lead the ACA implementation efforts for the agency. So that really was initially focusing on the 50-some provisions in the Affordable Care Act that related to HRSA programs, mainly around grant programs. So thinking about how we changed our program authorities and putting new money out, creating new programs like the Maternal and Child Health Home Visiting Program, the Women's Preventive Services Guidelines. We had some regulatory activity with the 340B program. So it was getting all that up and running. And then our focus kind of changed to, now that we were some of the early wins for the administration, some of the first activity out of the gate, as CMS ramped up their work with coverage expansion through Medicaid coverage expansion and the standing up of the marketplaces or exchanges, kind of how did those programs interface and impact with the populations that we served at HRSA? And so worked a lot with CMS on that. To make sure that our programs were aligning to get people the care that they needed as much as possible. And then really moved into the Affordable Care Act, looking at outreach and enrollment. So now that the marketplaces were stood up, the Medicaid expansion had occurred in some states. How do we get people there? How do we get people enrolled? And Dr. Wakefield, who is our administrator at that point, was really passionate about that. So we did a lot of work kind of trying to beat the drums and get people enrolled in coverage if they were eligible. And that's the picture with me standing with Secretary Sebelius at the time. We the work I led there got a secretarial award, and it was just really fun. And so then the ACA kind of died down a bit, and I ultimately was asked to direct the office I was working out of, which did all the policy research and external engagement activity for the agency. So I got to work across all the HRSA programs and really got to kind of see how health centers and our Title V maternal and child health programs and the workforce training programs and 340B and the rural health and HIV/AIDS, and how all of those just played a critical role in a safety net for people who live in this country. And then there was some change, that we had an election, and there was some changes in leadership, and I decided it was time for me to do something new. And so I went into private sector as a consultant, which is something I never thought I would do. But I found an organization, Health Management Associates, works primarily with states on Medicaid, but also does public health and Medicare. And really, they also focus on kind of access and serving vulnerable populations and working with programs that do that to make sure that they're running well. So a very different lens of being in private sector for profit, very different than federal, but still had that theme of access to care and working with vulnerable populations. And so I was there for 2.5 years, and it was great. I learned so much about the role of private sector in healthcare. I learned so much about kind of how different stakeholders think. And it was just a really good thing for me to kind of see the world out of a federal government lens and kind of more of a for-profit market lens. And then I got a phone call from Alan Morgan, who I've known for the 20 years I've lived in Washington, D.C., and he said that they were looking for a new person to run their government affairs. And so I said, yes, please. And even though it's not, again, it's kind of a circuitous route here, came over to NRHA. And even this is a new thing for me, because while I'm very familiar with some of the policy work and the administration work, I've never worked on the Hill. And so getting to kind of see how the Hill works, understanding the policy and the process and the motivations and making the relationships, it's a really good learning opportunity for me. So I think, and I forgot to mention kind of a side gig in all of this is I started my doctorate in public health 3 or 4 years ago now, 3 years ago, and I'm working on that in actually maternal mortality and policy levers in rural areas. So I find my people on this call, I think. But my point here, I guess, in the takeaways from my career is just, from my perspective, it's really, really helpful to get experiences that help you see healthcare or see whatever you're working in through a different lens, so that you really understand kind of when you're coming to the table to work with people, when you want to impact policy and make change, really understanding how they think, kind of what makes them tick, what are their incentives, what are the parameters and process that they're working within. And I think it makes you a better problem solver and a better negotiator and a better partner to be able to have that perspective. So that's me. I don't know how quick and dirty that was, but that's me. So next slide. So this is the team at NRHA that works on government affairs, Josh and I, and then we have a fabulous colleague named Mason, who is a North Carolinian native and came to us out of UNC Chapel Hill. I think not to assume that you guys know what the National Rural Health Association is, if I could just take a minute on that. So we are a national nonprofit member organization. We have over 21,000 members made up of kind of anyone who cares about rural health. So a lot of providers, as you can imagine, a lot of hospitals, physicians, rural health clinics. We have a lot of researchers and academics. We've got kind of community-based organizations. We've got kind of across the gamut. And the common goal is really to make sure that rural communities have access to quality, affordable care. And we focus on programs, policy, and kind of research in order to do that. So next slide. And I know that a lot of you, it sounds like, are pretty well versed already in rural health and some of the challenges facing rural areas. But, we know that there are about 60 million people living in rural areas. So that's about 20% of the population over a huge percentage of the land mass, if you looked at it on a map. And the like like we started the conversation, there are a lot of kind of unique features or unique challenges to the rural parts of our countries. So there are things like, and people use this adage, and I'm going to find a different one and a different way to phrase this, but the older, sicker, and poorer adage. So we know that 60% of older adults, meaning people who are over the age of 65, live in rural areas. So it's by far kind of an older population. There are higher rates of chronic illness. We know that people living in rural areas are more likely than their urban counterparts to die of the 5 leading causes of death. So there's a big disparity there. We know that there's lower access to critical services like primary care, like mental health and behavioral health services that we've talked about already. We also know that taking that context and then layering COVID-19 on it has meant a really challenging situation for rural communities. And while the incident rates of COVID between rural and urban are now pretty equal, the mortality rates in rural areas far outnumber the urban. So we know that the impact that COVID is having in rural is surpassing its urban and suburban counterparts. We've got issues like maternal mortality that you all sound like you're very aware of, that are unique in being able to get people access to care, to specialty services that are critical to their health. We also know that we have a lot of workforce shortages and challenges. Over 3/4 of rural counties in this country are HRSAs, or health professional shortage areas. And that holds true. I think the numbers are actually higher for the dental and mental health HRSAs. And we also know that the safety net that we are working within in rural communities is more vulnerable. So we've got higher rates of poverty among rural Americans, and especially around rural children, where 1/4 of rural children are living in poverty. And then we've got the infrastructure that's supporting them is more it can be more vulnerable. So we've had 135 rural hospitals closed since 2010. So even kind of the backbone of care in rural communities has some unique features to it due to payment methodologies and workforce shortages and other things. So not to be too negative, if you turn to the next slide, we also know that there are some really wonderful things about rural areas. And that ranges everything from, in my opinion, the quality of life that you can have in those areas. From a provider perspective, we hear a lot about the connection to patients and the high rates of patient satisfaction and that relationship. Rural areas have higher sense of community. There's very much of a can do and take care of your neighbors kind of mentality to it. And rural areas are really, really diverse, even though I think a lot of times we think of them as being kind of a homogenous kind of farm community. That's absolutely not the case. And so there's a lot of richness in our rural areas and rural communities to learn from. So next slide. If you think about kind of what we at NRHA are fighting for as we work on Capitol Hill and with the new administration, we have our efforts kind of focused in 3 primary areas. So the first is around addressing declining life expectancy and inequality among rural residents. So getting at those issues of health disparities, getting at the fact that rural folks have a declining and shorter life expectancy compared to the urban counterparts, and that was pre-COVID. So I mean, at this point, it's much exacerbated. So there's a lot that fits in that bucket. Everything from kind of social determinants of health and kind of race, income, geographic disparities and access challenges. Lots we can dig into there. The second bucket is around rural health workforce shortages, and we talked a little bit about that already, but how do we use our policy levers, everything from kind of the beginning of the pipeline in getting individuals interested in healthcare professions, going all the way through kind of the training programs, the residencies, getting those in rural areas, all the great GME work that Dr. Longnecker, excuse me, has done, it's thinking about what are those incentives and how do we get people trained and then distributed in rural communities. And then last is looking at the rural health safety net. And that's, I think, where the question of being able to have the institutions like rural hospitals in our communities, both as important economic drivers for the communities, but obviously important access points, and making sure that we can stabilize those facilities in the short term, and then really spend some time thinking about in the long term, what are the models of care that are right in our rural communities, and knowing that one size isn't going to fit all. So how do we create a number of different provider types recognized by payers so that we can help communities do a needs assessment of what's the right kind of mix in their setting, and make sure people have the access they need. So that was a lot. I can go and I can keep going, but I'm gonna turn to Josh now, and he's gonna talk a little bit about how we take all of that richness of what we want to do and think about what are the tools to make that policy change and influence policy at the federal level. So Josh.
Yeah, thanks, Carrie. So like Carrie said, we take, largely that message, put it into different asks, pieces of legislation. We find legislation that aligns with, those outcomes. And then we go to Capitol Hill and we try to advocate, and we encourage you all to do the same. So, I think the most important question is, what is advocacy? Because you see it on, TV and in the movies. It's likely a really contentious meeting where it's, high stakes. And that's not really how it needs to be. I think the most effective way to advocate is really to use it as an opportunity to educate, your member of Congress or your senator. You think about who these folks are. Oftentimes, if one of us ran for Congress, we'd have a good idea as to what healthcare is and outcomes that we'd like to see. But for me personally, I wouldn't know much about the business world or stock market. So everybody comes to being a member of Congress or a senator from a different angle and from a different, life challenge and different life goals. So, having that idea in the back of the brain is good, because it helps you educate and know and teach them where, we need to advocate and where we need to see greater outcomes for healthcare. And so it's really just the tool to educate and then let them take it from there. So you tell them what the issue is, why it's important to you, why it's important to your community, and then they'll move on to the next level. Next slide, please. And so why should you in particular advocate? I think what me and Carrie share all the time is that you care most about your community, your community, and you understand what is needed within your sector. Not only that, but you have knowledge and experience that members of Congress and their staff want and need. When I worked on Capitol Hill, hearing from folks like Carrie and I who are based in Washington is great, because you get really good background on the issue and you understand some of the data and statistics. But it's really important to hear how it actually impacts a provider in your community, individuals and employers in the community, because that's what they need to know is, if I, sign X into law, it does Y in my community. And that's the most important thing. And what my former boss always used to say to folks was, if you don't advocate, somebody else will. And not always will you agree with what they're advocating. So you need to get out and put your stories out there and let, folks who are making important decisions know how it's really going to impact real world folks in their own communities. Next slide, please. Thanks. Just a few tips quickly on how to frame message. I think the most important thing is explain your position, both problems and solutions, in really lay terms. Kind of like I said, not all staff members or elected official may come to it from a healthcare background. So, bringing it back to kind of the basic level is the most important. And then identify 2 to 3 critical points in your case. And most importantly, it's important to use data, especially tied to their district or state, to make your point. I always think it's really important that if it doesn't directly impact you, don't make up a story as to how it's going to do so. Just share, the community down the road is having this issue, and it's important because this could happen to us in the future, or whatever the case may be. And then along those same lines, always remember to be truthful, and your credibility is really the most important asset you have. I know coming from a rural community or rural state, I use, they say the 6 degrees of Kevin Bacon in film. It's like 2 degrees in rural America, right? Like I know a lot of folks who would come and advocate on Capitol Hill from South Dakota, and you likely would know some of their family members or whatever the case would be. And so creating that relationship, it helps the staffer and you want to reach out and talk about those issues, not even on the specified time frame of once a year. So it's really important to create those relationships. And next slide, please. Lastly, we just have 5 quick tips to remember when advocating. Number 1 is have a specific ask, co-sponsor S1234, support this bill, vote against this bill, whatever the case may be. Number 2, talk to a decision maker. Really try your best to reach out to the office and find out who their health LA is. Don't just send it to the, sometimes unmonitored email box. Try your best to find out who the decision maker in the office is and reach out to them. Number 3 is know who you're advocating and do your research. Like I said, not everybody's on committees of jurisdiction. So if they're not in the Senate on, the Finance Committee or the Health, Education, Labor, and Pensions Committee, they might not be intimately familiar with the piece of legislation that you're talking about. So that means you'd want to step back and do more explaining. Now, if they are on committee, you can likely move forward, assuming that they might have some knowledge of that issue. Number 4 is explain why it's important to you and other constituents. That's arguably the most important. And then lastly is be concise and make sure to follow up. If you tell them you're going to send something over to them, try to do so in a responsible time frame. You don't need to rush out of the thing and get on your computer and send it within 20 minutes, but just be sure to follow up and provide answers to the questions that they have. And lastly is how can you help advocate for rural health? Just quickly, NRHA does a lot of advocacy where we have pre-written emails and letters drafted by our team that you can send to your members of Congress and the administration, and we can share those with you all after the call, but that's based off where your zip code is. So if you just put your name and email in and your zip code, it'll go directly to your community. Attend local town halls virtually right now, of course, but try your best to speak with your members of Congress and understand what they're working on, what's important to them, and how you can craft where they're coming from into what policies you would like to see created on the back end. And then we have a few tools, the NRHA Rural Roundup and NRHA Today, that kind of keeps in touch with what we're working on with rural health. And then lastly, we do have social media, Twitter, Facebook, LinkedIn, that y'all can follow. And then Carrie and I's email is located down there at the bottom.